I think I'll go ahead and get started. Most of you know me. I'm Dr. Stacy Fairbanks. I'm an assistant professor here in the department. This morning we're going to be talking about geriatric anesthesia. We'll discuss the importance of the geriatric imperative or the silver tsunami, talk about some of the basic physiology of aging, discuss how we take care of our hip fracture patients, and then spend a fair amount of the end of the talk talking about postoperative delirium. So whether we like it or not, we're going to be taking care of more and more older patients. What is the silver tsunami? It's also called the geriatric imperative, and it refers to the aging of the U.S. population. So from 1950 to 2005, we had an 8 to 12 increase in seniors, which is age greater than 65. In 2013, they made up 13% of the population. However, right now we're in the very middle of the baby boomers coming to age. And so that increase is going to be doubled by the year 2030 to 72 million people. What's even more astounding is that the old is the fastest growing population of everyone. So in 2010, 5 million people were over age 85, and that number is projected to be 21 million by the year 2050. Those numbers are huge, 23% of the population, but what's even more important is that these are the patients who are our biggest consumers of health care. In 2013, age greater than 65 made up of only 13% of the population, but they consumed 25% of medications, 33% of hospital admissions, 44% of hospital bed days, and the majority of nursing home beds. That's a huge drain on our medical system. So what will happen in 2030 when the percent of the population doubles? Hopefully it won't turn into a situation like this, but no matter what, we need to be prepared to take care of these patients. So let's talk about the basic physiology of the aging patient. This is Jerry. Jerry is an 88-year-old man with advanced Alzheimer's dementia, and I recently had the privilege of taking care of him. He presented for left proximal femoral nail placement after hip fracture from a fall. He was actually found down in his kitchen in the middle of the night. He took only aspirin at home. According to his daughter, he probably could achieve 4 METs. His EKG was mostly nonspecific, and his exam was within normal limits. So how does Jerry and his physiology differ from the average Joe? Whether we like it or not, our physiologic decline begins at age 30. So most people in this room are already starting to fail. We see decreased conduction velocity, decreased metabolic rate, our kidneys become less efficient, our vital capacity decreases, and our maximal breathing capacity decreases. So let's discuss this system by system. This is where the audience participation comes in. So the polling is open. Jerry, our 88-year-old, what is his MAC for desflurane? Okay, we have about 50 responses. Okay. Most of you got it correct. B, 4.2%. So the way this is calculated is that the MAC decreases 6% per decade after age 40. So if you think about Jerry being almost 90, his MAC for desflurane will have decreased to 4.2 by the time you take care of him in the operating room. Other changes in the neurologic system, we see a decrease in the number of nerve cells in the CNS, decreased dopamine and increased muscular rigidity, an increased reaction time. You might see this when you question patients about their medical history. They don't answer quite as quickly as a 40-year-old might. We see an increased risk of postoperative delirium, which we'll discuss later in the talk. And then this decrease in MAC, so 6% per decade after age 40. If that's the only thing you remember today, then I've still succeeded. What about the musculoskeletal system? Our elderly patients have a lot of musculoskeletal problems. This causes implications with patient positioning and increased risk for pressure ulcers. So I try to think of the patient's risk for osteoarthritis and osteopenia when I do things like lithotomy positions. Often with urology procedures and our very old patients, I'll let them position themselves in the stirrups prior to going off to sleep so that I know their hips are in a comfortable position. I also think about this with hip fractures and total hip arthroplasties with positioning on the shoulder for a long period of time. And then the pressure ulcer risk is something that you can discuss with your circulating nurse and try to help prevent in our aging patients, especially with decreased nutritional status or very thin patients. Moving on to the renal system. Which of the following best represents Jerry's renal function tests? Will his serum creatinine be elevated? And will his GFR be decreased or increased? I don't think the polling is working for this for some reason. Does anyone want to throw out an answer? A little louder, I hear it. C, yep. So while the patient's kidneys will not be working as well, the creatinine will most likely be normal. So in the renal system, as we age, the GFR decreases by 30 to 45%. And because creatinine is dependent on muscle mass and body weight, we often won't see this manifested in our creatinine. So you might see an aging patient with a very normal creatinine, but a very abnormal renal function. The renal plasma flow is also decreased by about 50%. This should cause us to use caution with renally dosed drugs. And also remember that often these patients present in a really dehydrated state, especially if they come from a skilled nursing facility or are not very mobile and they depend on other people for their hydration. Okay, which of the following is most likely to be increased as a result of Jerry's age? So this is the pulmonary system now. Will it be his closing capacity, his total lung capacity, his diffusion capacity, or his vital capacity? Okay. Closing capacity, good, most of you got this correct. So in the pulmonary system, most of what we see in terms of physiologic changes results from a loss of elastic recoil and collagen. This leads to increased compliance, increased dead space, a decreased FRC, which will impact your ability to pre-oxygenate, and an increased work of breathing. What's interesting is the greatest risk factor for post-op pulmonary complications in elderly patients is actually the presence of ADL dependence. So one of the biggest questions that I ask my elderly patients is, what can you do at home? Do you take care of yourself? Does someone help take care of you? I try to find out what they can do in terms of independent living because this actually impacts their post-operative complication risk. Okay, moving on to the cardiac system. The normal aging process is most likely to result in increased myocardial contractility, decrease in LV afterload, decrease in pulse pressure, or decrease in maximal heart rate during exercise. Okay. Most of you got this correct as well. So a decrease in max heart rate during exercise. Everyone remembers the old thing you learned during med school. Max heart rate is 220 minus age. So as you age, your maximal heart rate decreases. So what else happens in the cardiovascular system? You actually get a maintenance of resting LV function. So a cardiac echo should show a normal ejection fraction that is the same percentage, 60, 65%, in a 40-year-old versus an 85-year-old. But the patients do have less myocardial contractility, so you sometimes get impairment of filling and then increased vessel stiffness with a higher systolic pressure and increased afterload. So this can lead to labile blood pressures, susceptibility to hypotension, and then volume overload with kind of an exaggerated decline in cardiac filling, in cardiac function with inadequate filling. So if you think about all of these different organ system changes, the biggest thing that happens as people age is the loss of functional reserve capacity, or the loss of ability to compensate in the face of stress. And no matter what type of surgeries our patients are having, it's probably stressful on their bodies, especially in the setting of acute illness or injury. So the curve that our patients are on, they're much more likely to fall off that curve as they age than they are when they're young and having surgery. Let's spend a few minutes talking about hip fractures and the best way to care for these patients. So why am I devoting an entire portion of my geriatric anesthesia talk to one type of surgery? Well, it's the quintessential illness of geriatric anesthesia or of aging. As people age, they're more and more likely to have hip fractures. 95% of all hip fractures will have some sort of operative treatment. So these are the patients that we see in the operating room. The reason why it's important for us to know how to take care of hip fracture patients is that post-fracture care can actually make a huge difference, and we're part of that. So a study out of Denmark that happened in the early 2000s looked at over 170,000 fracture cases, and they followed them for 20 years. What they found was that within the first year, 19% of patients died because of post-fracture complications rather than just their fracture occurring. So major causes of mortality were due to complications after the fracture event itself, not due to premorbid conditions. So looking back at Jerry, let's pretend that now Jerry's exam shows a whopping systolic ejection murmur. You have no echo, there's no previous recording of this murmur, but you know that he was found down in the middle of the night. So how do you proceed? Do you postpone the case and do a full cardiac workup, assuming he has critical AS? Or treat him as if he has critical AS and take him straight to the operating room? Or not worry about it? His daughter says that he can achieve 4 METs, and you just proceed with your originally planned anesthetic. Okay. So most people said B. About a third of people want to postpone the case for a cardiac workup. Well, this is actually a really good thing to think about. So we don't know the true mortality as a result of hip fracture complications, but there are a lot of reports in the literature suggesting that early operation is beneficial to the patient and decreases the risk of short-term mortality. So there is a meta-analysis looking at 16 different studies that shows that delays greater than 48 hours are associated with an increase in 30-day mortality and 1-year mortality. Overall data suggests that having surgery early decreases length of stay, decreases pressure ulcers and their complications, and decreases morbidity in general. It also just decreases the risk for postoperative delirium. So let's go back to Jerry having a normal exam. So assuming no other pathology other than his Alzheimer's dementia, how will you deliver Jerry's anesthetic? Will you do a general? Will you do a spinal with sedation, a spinal without sedation, or an epidural? A few less people are answering. Okay. So most people are going to do some sort of spinal with or without sedation, and about a third of people said a general. There isn't really a right answer to this. I was more curious, but we'll talk about what some of your choices are. So it doesn't matter what we do for hip fracture patients, regional versus general anesthetic. Well, there are some studies that say it does matter. Unfortunately, we don't have a lot of prospective randomized studies to tell us what to do. There is a huge comparative effectiveness trial done by Mark Newman, who's been here to speak before, that looked at over 18,000 hip fracture surgery patients in New York State. And they saw lower odds of in-hospital mortality and pulmonary complications with regional anesthesia. Since that time, there have been subsequent retrospective analyses producing conflicting results. In Taiwan, they saw a decrease in mortality and major complications with use of spinal versus general. And if you look at all of the journals, we see that surgery journals in general seem to say that the type of anesthetic doesn't matter or favors general anesthesia, while non-surgical journals say that spinal or regional anesthesia is better. In 2014, two different groups came out with consensus. The American Association of Orthopedic Surgeons say it doesn't matter, just get my patient to the OR. The Association of Anesthetists of Great Britain and the UK think that trying to do a neuraxial anesthetic is the best thing for the patients. It seems that this is a really difficult thing to study. Part of that is because primary endpoints are difficult unless you study it prospectively. A lot of databases don't have anything except for mortality or major cardiac events recorded. So it's hard for us to tell if a patient will go back to their previous residence, if they'll be independent, if they have good cognitive function after a hip fracture. Luckily, there are groups trying to study this, and there's a huge trial that should show results in December of 2021 called the REGAIN trial, where participants are randomized to general anesthetic versus regional, and it's a double-blinded study with the primary outcome being recovery of ambulation. I think this is especially interesting because a lot of our geriatric patients care a lot more about whether they're ever going to be independent again or be able to walk than they care if they die or not. They don't want to keep living if they're not going to be independent in some way. And so it's nice to see a study that's looking at some of the outcomes being more patient-centered. So let's spend the last half of the talk talking about postoperative delirium. It's impossible to give a talk about geriatric anesthesia and not discuss post-op delirium. Patients who experience post-op delirium often don't return to their previous residence. They're more dependent on the healthcare system, and both patient and family satisfaction are greatly decreased. So what is postoperative delirium? It's defined as an acute attentional deficit that typically occurs during the initial postoperative days. It occurs in 10 to 60% of elderly patients. It's a really wide margin, and the reason for that is that it's often not very well documented or very well noticed. It can manifest with hyperactive, hypoactive, or mixed symptoms. What we see is, especially for us as anesthesiologists in the recovery room, if a patient doesn't have active delirium or hyperactive delirium, then we don't know that they have delirium at all. We don't get to spend a lot of time with our patients in the recovery room. Our nurses aren't often versed in how to identify delirium if it isn't active. And so our patients with hypoactive and mixed symptoms can go days without having their delirium recognized. Delirium is a clinical diagnosis. There are no blood tests that you can do. And there are a few bedside assessments that have been found to help us identify delirium, the most common one being the confusion assessment method, or the CAM. And probably our ICU colleagues are very familiar with that because they do use the CAM in the ICU. Most of the studies I'll present today use the confusion assessment method as their marker for delirium. So just so you're a little bit familiar with it, the CAM requires the presence of an acute change in mental status with a fluctuating course, inattention, and either disorganized thinking or altered level of consciousness in order to make a diagnosis of delirium. It's a decent bedside test. It's 86% specific and sensitive and 93% specific. And then before we talk more about postoperative delirium, I also want to touch on postoperative cognitive decline, because many people think that they're the same, and they're very, very different. So postoperative cognitive decline is actually a decline in cognitive ability that occurs between 1 week and 1 year after surgery. Its incidence is thought to be 10 to 12%, but this varies with clinical demographics as well as when the patient is assessed for postoperative cognitive decline. What most studies believe now is that postoperative cognitive decline may be a real phenomenon, but if you compare patients who had surgery versus those who never did and look at them 6 to 12 months after a surgery or anesthetic, the amount of decline is actually the same between patients who have undergone surgery and those who haven't. So probably what happens is our surgical patients have a much larger step down in their cognitive ability immediately after their stressful event, but then that slows to be about even with our non-surgical patients months later. Both postoperative delirium and postoperative cognitive decline are very important for multiple reasons. It increases hospital length of stay. It leads to a functional decline of the patient. It gives them a lower likelihood of return to independent living. It increases their mortality, and it increases surgical costs. So the burden on the healthcare system from postoperative delirium is very, very high. And as we see more and more geriatric patients, we'll get more and more delirium, and that burden will increase. So thinking back to Jerry, which of the following is Jerry's most important risk factor for developing delirium in the postoperative period? Is it his age, the presence of a hip fracture, the fact that he's already demented before he goes to the operating room, he'll get general anesthesia, or an extended surgical time? Okay. So most of you chose C, which is the correct answer. However, a lot of these are risk factors for postoperative dementia. Jerry's age is certainly a risk factor. His hip fracture is a risk factor. And extended surgical time may be one as well. So what are our risk factors for postoperative delirium? You really shouldn't take care of someone over age 65 and not think about what their risk factors are for postoperative delirium and what you can do to try to help prevent it. So some of the preoperative risk factors that we really can't impact include age, lower education level, pre-existing cognitive impairment, current hip fracture, frailty, alcohol abuse, and previous poor functional status. With my patients that I take care of who are geriatric, I very frequently ask about cognitive impairment, and that can obviously be something that's a little bit touchy to ask about. However, a lot of our patients who have preoperative dementia don't have a diagnosis on their chart prior to coming to the operating room. So I usually ask little things like, how's your memory these days? Or ask the family how the patient's functioning in a cognitive way. I also ask if they still drive, because that's often a marker of their independence or their ability to navigate to home, to the grocery store. And all of these things kind of help me get an idea of whether they already have a little bit of baseline dementia. If patients are intelligent, they can cover that dementia up for many, many years before even their family members notice. And then intraoperative and postoperative risk factors for post-op delirium: infection, surgical stress, sleep deprivation, and then some of the things that we can help modify: cardiopulmonary complications, inadequate pain control, medication toxicity, so not using any centrally acting medications that we don't have to use, the presence of new pressure ulcers, and use of bladder catheters. So I always try to discuss with the surgeon about whether or not a patient needs to keep a Foley after leaving the operating room, or whether they can have diapers or a bedside commode. So which of the following techniques is most presentative for postoperative delirium? Do we want to give them as little anesthesia as possible, as deep of anesthesia as possible, or it really doesn't matter? Okay. So most of us said as little anesthesia as possible. I love that this is everyone's answer. I'm not always seeing that in the operating room. So let's talk a little more about how we can decrease the amount of anesthetic we give these patients. I think some people would argue that it actually doesn't matter whether you keep a patient deep or light, but you'll see here that most of our recent data shows that depth of anesthetic can be important. So the first couple of studies are actually looking at sedation with regional anesthesia and hip fracture patients. So did your screen just go off? I have slides. There's probably no AV person here. Anybody know anything about this system?
Somebody grab Crystal outside. Grab can call
Those aren't my children. Let me see if I restart the slideshow now, if it works. Okay. All right. So we were talking about sedation and depth of sedation with regional anesthesia. So this physician, Frederick Sieber, does a lot of anesthesia research with our geriatric patients, and he looked at over 100 patients undergoing hip fracture repair with spinal and propofol. He excluded patients with delirium that was already known and severe dementia, and basically there were two groups, one with deep sedation with a BIS of about 50, and one group that had light sedation, keeping a BIS greater than 80 and making the patient responsive to voice. And what he found is that the mean days of delirium and the actual occurrence of delirium were significantly greater in the deep sedation group. He then did another hip fracture trial more recently. All of the patients undergoing hip fracture repair at Johns Hopkins, there were 200 of them. They were randomized to either heavy or light sedation. However, this did not use a BIS, it just used an observer's assessment of their alertness. And what he found then is that the level of sedation did not affect delirium risk. However, if you looked at the healthy patients in those groups, so instead of the very, very sick patients with multiple comorbidities, but the healthier patients who had a hip fracture and not a lot of comorbidities, those patients who received heavier sedation had double the risk of delirium. So I think even here where he maybe argues it doesn't matter, probably less sedation is better. I don't know what's happening to this. I don't even know what I did to fix it last time, or I would fix it again. Did someone go get Crystal again at all? There we go. All right. So then looking at general anesthesia and depth of anesthesia, in China, they did a study looking at patients undergoing major non-cardiac surgery, so any surgery that was elective but expected to last for 2 hours or longer with an expected hospital stay of greater than 4 days. And patients were randomized to a group where anesthesiologists could do whatever anesthetic they wanted, but the BIS needed to stay between 40 and 60, or anesthesiologists could do whatever anesthetic they wanted and they were blinded to the BIS. And I found this study especially interesting. In the patients who had, had the anesthesiologist able to see a BIS monitor, the use of propofol decreased by 21%, and the use of volatile anesthetic decreased by 30% compared to the blinded group. What's even more remarkable is that the risk of postoperative delirium was reduced by 35% in the patients who were monitored by BIS, and their postoperative cognitive decline rate was decreased by 30%. The BIS-guided anesthetic patients recovered from anesthesia more quickly. They were out of the PACU sooner, and they also, interestingly, had a lower risk of infection. What's really great is that this study actually looked at number needed to treat, and for every 1,000 elderly patients that underwent general anesthetic, by using a BIS and titrating that BIS between 40 and 60, they were able to prevent 23 patients from postoperative cognitive decline and 83 patients from delirium. Probably in our ORs, we take care of at least 1,000 geriatric patients per year, maybe even 1,000 per quarter. And if we can decrease the number of post-op delirium patients by 83 every quarter just by monitoring by BIS, that's a huge change to the patient's experience as well as the drain to our healthcare system. So are there any intraoperative drips or multimodal anesthesia that we can use to decrease a patient's risk for delirium? So which of the following medications administered intraoperatively or postoperatively decreases an elderly patient's risk of post-op delirium? Is it dexmedetomidine, haloperidol, ketamine, or midazolam? Okay. All right. Good guess. I'm glad that no one picked midaz. That would be, so do not give your patients over age 65 midazolam. We will discuss dexmedetomidine and ketamine because there are a couple of really great studies that just came out. And then Haldol, I wouldn't recommend giving your patients Haldol routinely, but it is a good option for treatment if you are in a situation where you need some sort of centrally acting medication. So let's talk about ketamine in postoperative delirium. There was a study recently released that looked at giving ketamine bolus after induction and prior to incision to patients age 60 or older. And it was either 0.5 mg per kilo or 1 mg per kilo. And otherwise, the anesthesiologist got to choose what type of general anesthetic to give. So what they found is that there was actually no difference in delirium among the three groups. So whether the patients did or did not receive ketamine, they had the same rates of delirium. However, with an increasing dose of ketamine, more patients reported hallucinations and nightmares. There also was no difference in pain postoperatively or post-op opioid consumptions in the groups that received or didn't receive ketamine. There was also no significant differences in adverse effects. So I don't know that you can say that ketamine is harmful in these elderly patients, but it probably also will not decrease risk of postoperative delirium. I think that if the surgery is a very painful surgery and you feel like you need to give it for other reasons, then it's probably acceptable to do so in sparing doses. A couple of studies looking at dexmedetomidine. So in this study, the patients received, come on. I'm sorry about this, everyone. I have no idea why it's happening. Thanks. It seems to be a connection problem, but I just don't know I'm sure you're all in a lot of suspense about what happened with the Dex. Might not be working this time. Hey. So the screen just keeps shutting off. I think this is the third or fourth time. got it now. It's odd, but yeah, do you mind sticking around? Because this is, I think, the third. Oh, you are? Oh, okay. Okay, so in these patients who had general anesthesia, there was a dexmedetomidine drip or saline during surgery, and the drip was at 0.5 mics per kilo per hour. It was throughout the surgery as well as for 2 hours in the recovery room. The postoperative delirium risk was not decreased by using a dexmedetomidine infusion, and there was no difference even after age and education level were adjusted. The secondary outcome in this study was postoperative cognitive decline, and it also showed no difference between the two groups. Then there's a kind of recent study out of China that looked at patients who went to the ICU after major non-cardiac surgery. Some of them were still ventilated and some weren't. And the study was interesting. So the patients were placed on a very low-dose dexmedetomidine drip from their arrival in the ICU until 8 a.m. on postoperative day 1. And then their delirium was assessed twice a day for 7 days. And this group found that delirium was significantly decreased in the dexmedetomidine group versus the placebo group. This wouldn't be something that we would do intraoperatively. I found it kind of interesting. The study itself was good in terms of numbers, blinding, randomization. However, it failed to check for delirium or assess delirium in the patients preoperatively. So there was no way to know if some of these patients had delirium pre-op. It did also show that the dexmedetomidine group had lower pain scores, less tachycardia, less hypertension. So maybe it's a thought to maybe look into it a little further. Oh, excuse me. I guess it is per minute. Yeah. So it's not super low dose. So what do we do if our patients do experience postoperative delirium? Unfortunately, there aren't a lot of treatments available. Time is the big thing. Eventually, the postoperative delirium will go away. However, sometimes it takes days or even weeks, and it is truly miserable for patients. I've had patients come in who are having knee replacements, who had their previous knee replacement months earlier, and they talk about how they were so confused postoperatively that they had to go to a skilled nursing facility, and it just really is stressful for patients and their families. And one of the best things you can do if you know that a patient in the recovery room is delirious is to do continuous reorientation, and then if the nurse is willing, having the person doing that reorientation being a family member is actually better than just having the nurse do it. So having known family members by the bedside. Other small things that can be done postoperatively: early mobilization, good sleep hygiene, removing any unnecessary lines, drains, or Foleys. So if the patient doesn't need a central line or doesn't need an extra IV, just take it out. Be sure your patients have their hearing and visual aids right away in the recovery room when they wake up. Good pain control. So a lot of studies have shown that we're actually not great at controlling pain in our elderly patients because we think that we don't want to cause delirium by giving them fentanyl and Dilaudid, but we do need to make sure that we control their pain. And then most importantly, if their delirium is hyperactive and they're in danger of hurting themselves or others, do not give midazolam, give antipsychotics. Something that a trap I've even fallen into is I'm busy running a few ORs. I get a call from a nurse saying a patient is very, very anxious. Can she give him a little bit of midazolam or Ativan? I say yes, and then I go see them later, and they weren't anxious at all. They were delirious. So giving benzos can really prolong their delirium course. So in summary, delirium is important. There are not a lot of intraoperative things we can do, but there are a few things that I've found that help with delirium, and some of these are backed by data, and some I don't know if we'll ever get data for. So one of the biggest things is having a calm operating room when we go to sleep and when we wake up. Unfortunately, our surgical colleagues sometimes think that our wake-up time is time for them to catch up, show their Facebook videos, things like that. And so asking them to leave the room and waking our patient up in a calm environment is a good way to start their postoperative course. Avoid midazolam. Consider a BIS use in your patients. And then if you're going to use multimodal analgesia, the preoperative meds like Tylenol and gabapentin or pregabalin pre-op are actually the meds that help decrease their postoperative delirium more than our intraoperative drips. In conclusion, our geriatric patients are not just wrinkly adults. They have some special considerations. There's an age-related decline in physiologic reserve, and this is compounded by illness, cognitive decline, frailty, and polypharmacy. Our hip fracture surgeries, patients, if you can do one thing for them, give them surgery early. Don't let your partner do it the next day. And think about delirium in all of your patients. Thank you. Thanks for your patience with the AV stuff. Tony.
How aggressive would you be in your patient that has a fracture in terms of the neuroaxial technique? You know, if they can't sit or would you do a lateral? How aggressive are you?
Yeah, I'm actually pretty aggressive if the surgeon will let me do it. And what I find is that if you roll the patient onto the hip they broke, it helps stabilize the fracture and they're much more comfortable than if you roll them the opposite direction. So I've often gotten spinals in that way. Just roll them on the operative hip, throw in the spinal, and then position. Brendan?
Lucy, one of the things that Dr. Janik spoke about a few years ago is actually that it's not a marker of depth of anesthetic. You know, throughout all the awareness trials, it's really been shown not to decrease your rate of awareness, but actually a surrogate for perfusion, for cerebral perfusion like we use in cardiac rhythms a lot of times and in neuromonitoring. That there have been some instances in some of the safety literature where actually pumping up the perfusion pressure seemed to change your BIS number quite a bit in elderly patients or patients undergoing carotid surgery.
Yeah, so there aren't any studies that have been able to show us that severe hypotension, well, I shouldn't say severe, but that hypotension or any sort of cardiac instability definitely leads to post-op delirium. So it's hard for me to make that connection for sure, but you're right about the BIS not necessarily being a marker of depth. So I guess monitor it and try to keep between 40 to 60, even if you don't know that that means their depth is how you want it, or if it's their cerebral perfusion. Does that make sense?
And there was one other, I think it was a study last year in anesthesiology that looked at pre-op the mini-cog test that they did on patients undergoing elective orthopedic surgery. And what was like blown out of the water was how many of these patients had pretty significant dementia going into surgery that family members had no idea. So
Yes.
an emergency surgery like they're talking about, but coming in for their elected knee and hip, and that they were like, wow, I had no idea my husband was so demented.
Yeah, patients are, yes, we get a lot of demented patients where there's no dementia charted anywhere on the chart. And that's why I try to ask those questions of like, you know, how's your memory? Do you lose your keys really often? And I ask the patient, but I look at the family's faces because the patients will be like, oh, I'm fine. And the family's back there saying no. So.
They followed those patients and
Yeah, I would believe that. I try to just treat everyone over 65 as someone who's at super high risk, whether they're demented or not. But Leslie?
Just two comments. One clarification. The use of the word "this" is the equivalency for a processed EEG. Okay? And so it's like Kleenex. You know, Kleenex is a facial tissue, but I don't know. I think so. We just have to be careful about that because there's a number of companies that are available and they all have somewhat different absolutely bang on that we can't tell the difference between hypoperfusion and to deepen anesthetic because the effect on your brain is really identical.
Mm-hmm.
Decrease in electrical activity. And that's what the EEG process or otherwise actually measures. And we have to think about that when we do this so that maybe just a normal blood pressure, like some of these new papers that have been coming out suggest, is good for people. You know, normal blood pressure, all those kinds of normal urine output, all those kinds of things normal is normal eventually.
Yeah, I agree. I think the biggest thing, though, that I see is that people are so afraid that our patients are going to have intraop awareness that they're running 70-year-olds at an end-tidal SIVO of 2.2 with a phenylephrine drip at 1. And I don't think that that type of normotensive is the same as running them at a normal MAC for age and no phenylephrine infusion or a much lower phenylephrine infusion. Oh, I had no idea. Yeah, that's great. And that's one thing I did fail to mention is that even though early surgery is important, one of the most important things we can do to decrease post-op delirium that's been shown time and time again in the literature is a geriatrics consult. So I would argue for a geriatric consult for your patient prior to taking them to the OR. And luckily, our ortho service is pretty good about getting that right away. Any other questions or comments?
There was an article in Anesthesiology that looked at the retrospective analysis of the fractures, and they actually found that hospital-wide use of spinal versus general was a better predictor for outcome, which is really interesting. So, if you went to a hospital that did a lot of spinals, you would have, they were suggesting that you would have a better outcome regardless of whether you got a general or spinal or not. I don't know if you got a chance to see that.
Yeah, I saw that, and that's also it's encompassed in that comparative effectiveness research with Newman. I'm pretty sure Newman did that study as well in anesthesiology. I think the biggest, I think that that's true. So it looks like centers that do a lot of spinals, you want a spinal, and others you want general. I think the thing that always confounds that data is that they very infrequently, when they look retrospectively, are able to tell how much sedation a person got. So did they basically get a general with no tube with their spinal, or did they get almost no sedation? And I think that makes a really huge difference.
I think what they were trying to say was that, regardless of where the individual patient got spinal in general, as long as the centers were kind of moving towards a process where you're trying to, do the right thing for the patient, whether you can argue that it's actually the right thing for the patient, but, trying to improve pain score, improve the patient's pain, minimize delirium, and avoid generals, that may be even better for the patient rather than the individual anesthetic they have to get.
Yeah, good point. Okay, thank you. Yeah.